The Core 360 belt is the best aid to train the abdominal wall. The Core 360 is a patent-pending, first-of-its-kind training belt that helps you move, breathe, and perform better. We use the Core 360 belt with almost every patient at Winchester Spine and Sport. The biofeedback is second to none, and it's an amazing way to teach proper respiration and can be even used during higher-level movements in the gym. Teaching proper respiration is about as fun as a rash, but with the Core 360 belt, you take all the headaches away. Visit core360belt.com and use the code GESTALT for 10% off all belts, ohm track sensors not included. Again, visit core360, core360belt.com and use the code GESTALT for 10% off. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Brett, we are in Idaho Springs, Colorado. So, man, I've heard so much about this workshop that I've never seen in person, and it lived up to the hype. So, we're here at Extreme Footworks with Shawn Eno. He basically builds the best orthotics in the world.
Yeah.
You've been through a lot of people, and so you've been on our list for a while to be down here and to see your workshop and to see how it all works. And I mean, it is impressive to say that this is a work of art, and these little things that go in the bottom of the shoe are truly a work of art. So that's
Thank
pretty
you.
awesome. So Shawn, we're going to start today. So you're a Pedorthist. What the hell is a Pedorthist?
So a Pedorthist is one who conservatively treats the foot through the use of custom foot orthotics and shoe modifications. And then I'd like to say that we gathered a little bit of soft tissue experience in this office too. We treat some neuromas up through the foot with some tooling and myofascial release. But it's our goal to change the way that someone moves through stance phase with a brace, basically. And so we're lumped in with the prosthetist and the orthotists. We're just basically body bracers, and we specialize in feet and lower quarter.
And what goes wrong? As a species, if, we would say, we're born and, everything is quote unquote neurologically perfect at that time. As we move along in our life, what requires us to need an orthotic down the road?
So I like to tell folks out the get-go that we were never meant to repetitively stand and walk on man-made surfaces. The health of a foot comes from the maneuvering of that foot over a variable terrain and also the pirouetting of the body over that foot. So, we have this redundant standing, walking forward type life that we've built, and we've made everything hard and flat. And if you just peel back life a couple hundred years, we were walking over terrain that required different positions of the foot beneath the talus, basically. And that adjusting to position created intrinsic strength in feet. This is without even going into the discussion of the next point will be like deformities and things that really require orthotics. But like anybody, even with really good biomechanics and good feet, who say takes a job for the post office working at a sorting station for 20 to 40 years, is going to one day go to the Dr. Scholl's station, go to their doctor, say, my feet are killing me. What can you do? And the reason those feet are killing them is because they've gotten weak inside shoes on redundant man-made surfaces, and now they're just getting pounded by their workstation. So that's the first thing I tell them. The second thing is we're born to a rounded womb environment, right? So ontologically, many of us have small moms, and that can be a player, but we also see curves and twists and leg length differences kind of run through families. So the question is it because all of the moms had this size womb, or is it because those types of biomechanical deformities are somewhat congenital or running in families? But if you are from, say, a smaller wombed mom, you may come out of the womb with more curvature, particularly in your tibias, and you've got that, 5.5 years roughly to rotate down to the transverse plane, and most folks don't get there. So as a result of tibial varum, they are predisposed to walk on the outside of their feet, and they have a pronation requirement just to get down to a flat man-made surface. I use the analogy, imagine if that same set individual with moderate tibial varum walked across the infield of a Major League Baseball stadium, they would leave these perfect little orthotics in the dirt, right? Where the dirt filled their arches and the outside of their feet sank deeper in the earth, into the dirt than the medial sides of their feet. And we get no ground adjustability anymore. It's like getting slapped in the bottom of the foot with a frying pan. So if you've got more curves and twists in your lower quarter, then the demanded range of motion out of your feet to find foot flat, which is the transverse plane, which is a plane tangential to Earth's gravitational axis, basically. We call it level, right? You put a marble in the middle of the floor and it doesn't roll anywhere. That requires that pronation. They're going through eversion, pronation, and we get a couple subsets from that. We get the overpronator, who then unlocks the foot and can't resupinate correctly for toe off. Mm-hmm. And we get the underpronator, someone who doesn't possess adequate range of motion in their feet to make up for their tibial varum, so they remain supinated and walk on the outside of their feet. So it's like an augment, you know. If everyone's in the park, their on the grass, their biomechanics doesn't look that bad. You put them on the institutional floor, and you're like, ooh, ah, ooh. That's why I'm always fascinated by the airport, because it really brings out the worst in biomechanics.
That's absolutely.
Tom Michaud here talks about this researcher named Rausch that looked at different socioeconomic classes. And what the paper talks about is the people that were barefoot early on, how they actually developed three arches of the foot, and like the higher socioeconomic kids who they have shoes on at a very early age, how they develop with a flat foot. Whereas everyone was always thinking ontogeny and things like that. However, like footwear actually is playing a huge role in those first 6 years.
Yeah.
Yeah.
And have you ever noticed how your 2 and 3-year-old take their shoes off at any moment they can?
Right.
And you can't find their shoes because they're like, I'm going to hide these over here because I don't want to wear them anymore, and kind of foil mom and dad into finding them. Because at that age, they're just on autopilot and their brain's telling them, this is not good. And they take them off, and mommy's like, put your shoes back on, and that story gets told over and over in many households, I think.
Right. So let's start by just saying, what is your fascination with the foot? Like, how did you even begin this journey?
Well, I was in college and I was riding home from school one day on a motorcycle in downtown Kansas City. I was doing my undergrad at UMKC, and I got hit by a car while riding through town through an intersection, and my tib fib, about 4 inches above the malleoli, was smashed almost to non-connectedness by my engine block and a 79 Cadillac. So I was immediately given a very poor asymmetric gait. They barely saved the foot and reattached it. And I began to struggle with all kinds of issues. And the real blessing part of this is that right out of that doctor's office, you go in there and you're 19, like, what the hell do I do now, doc? And he farmed me down the street to an old school Pedorthist who built the best orthotics I've ever had. Wow. So fast forward a few years, I'm pursuing my degree and trying to find work in my field, and I'm just breaking down all over biomechanically. You would think it would just be the foot and the leg bothering me, but I ended up with a massive amount of hip and low back pain, and therefore we couldn't, I couldn't function without it, okay? So in essence, and therefore, I needed that guy's services, and when I finally did something stupid and threw those in the trash because they were falling apart, your patients come in and the front of the orthotic just wants to fall off, etc. Threw them in the trash, and then I started falling apart because they were doing way more for me than I gathered at that time. So I went to look for him. He passed away. And I struggled for a little while to find anyone that could do anything similar. I went through podiatrists, no offense, I went through quite a few chiropractors, foot levelers, all this garbage. And when I found someone that could do it right again, they were in this town and they were running a little boot manufacturing facility. And because he was having problems with custom-made boots that he made, he backed his way into Pedorthist. by having to figure out what these feet were doing in the shoes. And that's how I came to be a Pedorthist. I said, you need to give me a job. Nobody knows about this. Like, there's just nobody doing this kind of work. We need a lot more people with this skill set. And I took a traditional apprenticeship in this town and passed my boards about 6 months later, and that was it.
That's crazy.
When you and I teach together, we one thing that the chiropractors or physical therapists want to hear is, what is the foot type, or what are the problems that we're going to run into that we're not going to get better with manual therapy and rehabilitation? And you and I, over the years, had kind of come up with 4 things. We came up with tibial varum and
Yep.
functional hallucis limitus,
Yep.
uncontrolled pronation,
Right.
and what was the 4th one?
Supination.
Forefoot varus.
Yeah, forefoot varus.
Forefoot varus.
And another one we could throw into the mix is the Morton's toe. Because what Morton's toe sets up is a situation where the first ray can't plant the MPJ down on the ground at the same time as the other 4 met heads. And there's a further travel into pronation with the Morton's toe. And that's what Rothbart writes about, which is just simply so many feet have a short first ray. And so they really destroy that first ray because of that extra distance traveling to the loading surface.
Right. Has the Rothbart idea or concept, is that still alive and well? Or
Yeah, I work with Robert Lardner sometimes. He's a big fan of him. He likes a low, long, corrected arch with a Morton's extension on it. He doesn't like the high-arched, closed-packed position espoused by, say, some of the labs we know that talk about full contact casting and how, we do want a full contact arch. And so in his case, he's always sending me slightly pronated casts, like somewhere halfway between this non-weight bearing style that we cast in and the full on stand in the box concept, which we know captures too much compensation, right? So they tend to be lower back under the subtalar joint, but then run out under the MPJ.
Mm-hmm. There's been some research recently, and I'm not saying I agree with it, but I'm curious to hear what you say, where a prefab or like over-the-counter orthotic can sometimes outdo like a real orthotic or a custom orthotic. So when you see research like that, like what do you think about that?
Basically, I think that unfortunately there's just not a consensus on how orthotics should be constructed. Mm-hmm. You've got the whole podiatric industry that they're kind of guided by a couple, shall we say, flaws in their biomechanics. So Root, Orion, and Weed's biomechanics, right? They talk about some things like medial heel skiving, for instance, is one of my pet peeves, because I think all of us, when we're trying to put a heel down on the ground, are seeking the closest facsimile between the plane of the base of the heel and the supporting plane. We don't want that foot walking on the outside or the inside of the heel. And if you skive a cast, which is akin to rear foot varus, you're already casting that foot into rear foot inversion, right? You're basically creating a block that prevents them from reaching the transverse plane. So there's one huge one. Another one is because that industry has decided that the most effective cast is an open chain plaster bandage wrap cast, or another method is pushing the foot in kind of a box or using a cane to evert the lateral column. We get long, low arches out of that type of cast, because you can imagine if you're not using the windlass effect to create an arch, say the DNS short foot, for instance, where we can see what that arch would look like if it weren't under a burden and relaxed. So your patients raise their toes up and you see what their arch should look like. We just have these labs that there's a two-pronged approach to it. One is the blanks that they use to mill out the shells for these standard podiatric orthotics are often not as thick as, say, a higher arched individual. If you can imagine, the thicker the blank, the more the blank becomes waste in the trash, and the less of the blank becomes the device. they have gone to what we call an arch fill. So they'll take an arch unless you are adamant and say, I want this original arch, I want it high. They'll fill the arch of the cast so that their blank will cover the height of the midfoot. So most of the podiatric orthotics that we're seeing these days are too long and too low in the shell. And then they choose, because it's easy to mill on a mill, polypropylene, they choose these hard shelled materials, and they don't offer EVA. Most podiatric labs don't even offer an EVA product, because then they can spin them off this mill for, $10-20 a pair and sell them to the podiatrists, who somehow in this country got positioned as the preeminent orthotic providers, right? And you're supposed to go to them. But if we had a room full of 10 podiatric patients, different podiatrists, each with an orthotic from that different office, and we had them stand in front of us barefoot with their feet out and put their orthotics on the floor, the variation in the appearance of their feet would be much greater than the variation in the appearance of their respective orthotics.
Well, and I mean, that's a problem we run into. The orthotics oftentimes are just too rigid. Like the acrylic ones are obviously too rigid. And EVA offers like the perfect density of substance where you're still able to offer support, but then it is like the perfect amount of forgiveness, because if you take your patient's orthotics out of their shoe and you let them stand on it, oftentimes you'll see, like the acrylic ones are obviously too rigid, but then the other ones, without naming certain names, they just pancake out. And then you see, basically at that point, you just have a glorified, Dr. Scholl's foot pad, basically.
Right. And that's where, this is the other complaint I have about these labs, is they want all this business, and they want to just spend these orthotics out the door. But the last thing they want to address is the need for extrinsic postings. You know what I mean? Like they don't want to take the extra time to install met pads, do cutouts, do first ray extensions, do valgus posting, do rear foot posting. And a lot of times that doesn't turn out well. So in essence, their version of preventing excessive overpronation is to catch the heel at an angle and to stop it from fully everting to the supporting surface. Versus this is where I do agree with some unnamed individuals, where we need to really pick up the foot just proximal of the medial heel, underneath that fleshy portion of the foot that will take more pressure, that's literally under the talus, it's a subtalar joint, and hold their maximum correction beneath the subtalar joint. Right? And then, as you said, if they can get the first ray down, which that's the fallacy with too long of a shell, right, is that they're left with a met primus elevatus, basically, and they never can firmly get the first on the ground. That's also why a lot of podiatric orthotics will lead to neuromas, because they're subtly pitching that foot into forefoot supination at toe off. Versus when you draw the foot into the short foot position and cast that image, you have a shorter, taller arch, and you'll notice in arch shapes that the arch center is actually about 2/3 of the way towards the heel from the front shell edge, instead of dead center, which is most of the time what you'll find a podiatric orthotic is a dead center arch. Well, if you look at the profile of this foot model right here, it isn't a perfect half sphere, right? It's more of a kind of an altered, I forget the geometric term for it, but it's more of like a teardrop where it's taller right under the subtalar joint, and then it really needs to follow the first ray declination angle down to either 0 or your first ray post if they have a Morton's extension. So you want to control subtalar pronation, but then still give them every opportunity to evert and lower and load both the MPJ and the FHL. And then you throw the monkey in the wrenches, they've got, 0.8 seconds in a stance phase to get that done. So if they have no range of motion, limited range of motion, or structurally fixed into supination, they have almost no chance to utilize the first ray properly. And that's where we get that other type, where they're underpronators. They don't pronate sufficiently for the mechanics above the ankle, right? So you've got a rigid, high-arched foot and a moderate to severe tibial varum. How does that person load the first ray when they don't have enough eversion range of motion to get to the transverse plane they're standing on?
And that's a foot you and I have talked about quite a bit, because you see that foot cosmetically, especially from behind, and it looks like it's basically inverted. And it is. And I remember having this conversation with McPoyle years ago, because he's like, yeah, that foot needs eversion. But I remember like trying to explain to him, like, if you understand joint play though, like if you joint play that foot, obviously they have really stiff articulations in the mid-tarsal joint, midfoot, but then like their subtalar joint, I mean, they're hypermobile into eversion.
Right.
So then you get to this crazy dilemma of like, okay, so do we still pitch them into eversion, or, you know, are we going to get creative with how we post the rear foot and the forefoot? And I mean, and that's the most difficult foot that exists for all of us, because, you know, what do we do with it? You know?
Yeah. I mean, if they don't have any range of, or a limited range of motion, then you're restricted in how much position change you can acquire for them in stance phase.
Right.
They're only going to tolerate so much.
The other thing I've kind of like really kind of learned in the last couple of years is the formation of the Sustentaculum taillight is different in everyone also. So like you have this beautiful little shelf on the calcaneus here, and how that develops and forms basically determines, you know, how many articulations you're going to have in your subtalar joint and other things. But anyways, the overly pronated foot that you and I have seen, where the navicular is just sitting on the ground, they're most likely going to only have one joint in the subtalar joint. Therefore, structurally, they are just crushing the soft tissues of the medial component of the foot. The spring ligament, the plantar fascia,
and
all those.
That spring ligament runs underneath the anterior facet, doesn't it?
Yeah.
It's supposed to spring on top of it.
But what they found is there's actually, in the spring ligament, there's actually not that much elastic fibers. So it's essentially kind of like a hammock.
Yeah.
And then that hammock, though, over time, because of creep, hysteresis, and set, is basically now just it's just an elongated mess, you know?
Yeah.
So because of that, these foot, I'm now like learning to appreciate, where I think we all have a moment in the world of rehab where like, oh, we don't need any support there. We can teach them how to exercise. But then, like, I mean, if we're honest with ourselves, some of these people, and we've all seen them, like where literally their navicular is sitting on the ground, like they are going to require some kind of support, and you are only fooling yourself at that point if you don't think so.
And back to your original question, which is how does the clinician or the patient care provider decide when their modalities for rehab, right, aren't enough to get the patient well? What foot type lends itself to the definitive need for an orthotic intervention? And I use the spinning top concept, right? So if that foot's in the ballpark of the sagittal plane as you're looking at them, and they're neither full overly inverted or everted relative to that foot's sagittal plane, then you really only have a little bit of adjusting that you're trying to get out of that foot, and then your rehab and your other modalities may work. But if they are just so far, past the point of return, where we all know a spinning top reaches a certain degree of angle and it just falls over no matter how far it's spinning, same thing goes if they massively overpronate, or they have a structural limitation like we've already discussed. Morton's toe is a perfect example, or forefoot varus. Then they simply do not have the capacity to get through soft tissue to a more neutral foot position through strengthening and rehab, i.e. they're losing that battle because they can't overcome the forces of gravity in their foot.
Right.
Another one is simply where if they can't create a transverse plane out of the base of the heel, the fifth med head, and the first med head in your office, because of some structural limitation, once again, like forefoot varus or the high arched rigid cavus foot with a forefoot valgus, then you can say to yourself, well, this patient has no hope of achieving a full transverse tripodal plane out of their foot. We're going to have to do something, or they're going to continue to over-evert or over-invert.
And why does it have to be so binary? Like it doesn't have to be like, well, just because I'm using Shawn Eno for an orthotic doesn't mean we're not rehabbing their foot and doing soft tissue.
It has to be all of it.
Yeah, it's a multimodal approach.
Right.
I think it's hearing you guys riff like this is a great example of what makes you a little bit different. Is that I've overheard conversations that you're having with Brett about patients, literally about these things. So that's a little bit unique, I think, in building an orthotic, is that you're talking about these types of things of like, this patient has this type of thing. Okay, well, have you checked this and that kind of stuff? And so I just think that that's a really unique thing. You usually, if you work with somebody that's casting orthotics, you send them the cast, they cast it, and they send it back, right? So This is like true custom orthotics, right?
Oh yeah, because we call it orthotic therapy. Because I mean, you don't always get it right. I mean, sometimes it's we're
and they only do so much. Like the one thing I always set my patients up with is the expectation that this isn't a black and white outcome. This is just better shades of gray.
Yeah.
Right? You can still take 30,000 steps on Saturday and you'll be right back in that same state of dysfunction, but you will have taken 2 or 3 times as many steps to get there. Because you're still in compensation, but you're compensating less, giving you more mileage.
The three of us, I think, are all amazed at the ability of the human being to adapt and to compensate to things. Like if you see the person who does have their navicular just sitting on the ground, you see an abductor hallucis that is just like so overly developed, which is one of the muscles that's been shown to stiffen the foot of the arch of the foot.
Yeah.
So I think sometimes that's what happens too, is like we put in this beautiful structural correction, but then they've had 30 or 40 years of adapting to their crappy structural situation. So then we got to have another kind of adaptation period that kind of has to occur for them to get used to the orthotics and.
And, if you as an orthotic therapy provider aren't willing to accept the dynamicism of your patients, meaning that this isn't also providing orthotics isn't black and white, because you may change them with the orthotic and change their compensation pattern, so much so that then you go back and reevaluate what the orthotic is and you have to change it because they've adapted, and the presentation in front of you is a more pure presentation of what they would look like without some assistance. So for instance, if someone comes in and they're already middle-aged and they've had a bad case of forefoot varus and they present with true changes in the structure of the bones of their feet, then we might get X amount of correction out of the first cast, dispense a set of orthotics, watch them improve greatly, and then realize, hey, I think I could get a better cast out of this foot now because we pushed it from whence it came, right? And then you cast them again and you realize, hey, this cast looks even better than the one from a year ago, because you kind of tipped the scales, so to speak, and put them back in a place where their soft tissue actually can be recruited to assist them, versus that tipping of the spinning top where they're so laid over that unless we get them tipped up halfway, we can't get them to fire those muscles and ligaments and help themselves because they're past that point. So we get them back past that point towards good, and then we see, oh, wow, it looks like maybe we could do even more with this foot.
Do you ever, have your clients or patients, sometimes they just do this naturally, but like they get to a point and you're like, you no longer need your orthotic. Like the orthotic therapy was just kind of a temporary thing for like a year or two, whatever, and then they discontinue? Or do you feel like by the time you've decided to put an orthotic in their shoe, this is probably going to be a lifetime sentence for wearing orthotics?
Well, generally speaking, my patients are older. So if I get younger patients in or post-surgical patients, then there's a good chance that we can rehab them out of the orthotic if they're not too bad of a case. What does that mean? Meaning they're not struggling with a major biomechanical deficit. Maybe they just injured themselves running. Maybe it's a chronic injury they can't get past, and we need to kind of help them out to get past it. In essence, if they're younger and their cases aren't that bad, they're athletic or they're post-surgical, there's a chance that orthotic can be pulled at some point. But most of the time what happens is people present in this office with blaringly obviously bad biomechanical situations. We call them deformities. Now the book says malalignment syndrome, I think is what it says, right? So if they have a malalignment
correct.
and they're trying to move with a malalignment, right? So knee, hip, and foot don't line up, then they're going to benefit from the orthotic, and they should have it on much like a set of glasses for someone myopic for the rest of their lives. Yeah.
What about lifespan? Like, so you talked about your own orthotics from your original kind of wearing out. So in the perfect world, those patients that you think are kind of this is part of their life? Like,
Yeah.
how often should they be cast? How often are you remaking their orthotic?
So we offer a refurbishment because the one component of an orthotic that sees the most wear is the cover that goes against the foot. And that's to interface and to replace the factory insert, right? Because otherwise we could make 3/4 length orthotics and just plop it in the shoe's factory insert, and that's what we would use as the front of the shoe's factory insert. But it's those forefoot pieces and directly beneath the heel that completely pack out and become harder against the underlying higher density EVA shell. So we say, send that puppy in for a resurfacing. We can resurface a pair of orthotics 1 or 2, maybe 3 times in a 5-year period, but most orthotics are a 4 or 5 year equation, and then they need to be replaced.
Remember that when I sent you, the lady had tried to clean them with Windex or something?
Yeah. And you lost the top out of them, so she was sliding around all over the top of them.
Yeah. At least she was honest about it and didn't blame someone else on it.
But then you're saying that 4 or 5 year route, as long as they're still happy with it and they're feeling good, no reason to really reassess or anything. You're basically just going to rebuild the original.
You can take and put them on the floor and perform the DNS short foot. You can also perform what was once called the Fowler test, which if you go up onto great toe dorsiflexion, you're going to naturally get your arch, and then you trace the orthotic up to the arch. And if you see a gross deviation of the shell beneath their foot, meaning that they've not only just worn the cover, but they've packed out the shell, then that's a visual for you to determine a replacement.
Redo it.
Yeah.
Got it.
Okay, we're going to play a fun little game. Have you ever seen Pardon the Interruption on ESPN?
I have not.
So basically, we're going to do like some real quick hitters with you. So we're going to throw you a diagnosis. You're going to say from the orthotic standpoint what you would do, and like we're talking like 20 or 30 seconds.
Got it.
So we can't ramble on. We're just going to throw it to you. We do this on purpose just to keep us all on point here.
Yep.
Morton's neuroma.
So Morton's neuroma is going to be treated with an orthotic that addresses why they may be overbearing weight on the lateral forefoot during stance phase. So we're going to tweak the orthotic to provide perhaps more first ray pressures and guide them onto the first ray if we can. We're also going to use a met pad to spread apart the metatarsals and unload the distal met heads. And occasionally we put wells in the covers if there is, say, a plantar flex met head involved. And then I would recommend to any practitioner to try to basically expose the neuroma with their fingers and tick away at that neuroma on the dorsal surface, primarily of the foot, with a blade.
And the met pads go more proximal than most people think that they do.
Yeah, we want to snug them up right behind the met head so that they're not standing on it with the met head, but almost standing on it with the met head. And that's why we use the pedographs that we ask you to send, because your cast is basically a non-weight, non-splayed foot, and the pedograph is an image of what that foot does uncorrected in stance phase.
Functional hallucis, limitus, and rigidus.
So in that case, the way to make a person able to walk across the first more pain-free, because we'll see an avoidance pattern for those two pathologies where they supinate and move away from the first at toe off, is to extend the shell underneath the first MPJ, the first met, so that the demanded dorsiflexion range of motion through toe off is decreased by adding that rise over run.
Right. Mm-hmm. Versus a first ray cutout.
Versus the first ray cutout would demand more great toe dorsiflexion.
Right.
Right.
It's interesting, though, because different experts in the world have different opinions on it. Yeah.
I think the first ray cutout is for somebody with a plantar flex first met head.
Right.
Because then you want to drop that relative to the other 5 so that they don't tip and fall off of it, because in most cases that plantar flex first is attached to a more rigid medial column style foot.
Tricky one here. Hallux, abducto, valgus, bunion.
So bunions can happen in both cavus and overpronatory feet. Bunions are evidence of excessive forces being applied on the first ray through toe off. That's why it can happen with the supinator and high arched foot too. Typically, you want to address the underlying deformity, which in most cases is Morton's toe or forefoot varus, because that continued overpronation in the forefoot is what leads to the formation of bunions. So whereas they say bunions are hereditary, they're not hereditary. It's the mechanics of the feet that are hereditary.
And the loose connective tissue.
And the loose hypermobility of the tissue. And then the foot, most feet respond in the same way, and the first ray breaks down classically into that.
So there's no special treatment for bunions from an orthotic standpoint? Like to give them symptom relief?
Forefoot varus posting if they still have flexible bunions, because you're decelerating that forefoot pronation, which is the cause that lent itself to the formation of that. If it's a rigid cavus foot with a bunion, then it's going to be forefoot valgus posting, so they bear more weight under the other four med heads, unloading the first. Because really what breaks that toe down into the hallux abductor valgus is excessive plantar MPJ forces.
Perfect. Or rocker bottom shoes, Hoka, we could go that route too.
Yep.
Plantar fasciitis.
So plantar fasciitis is... there's two classic presentations. One is the rigid foot that is a poor shock attenuator, okay? And in most cases, those rigid feet are a little bit higher arched. They don't have any calciversion. They basically have a prominent plantar fascia band that if you dorsiflex the first ray, you see it just bowspringing down there like a piano wire, right? Mm-hmm. And they, in essence, need a sweet spot in the heel to attenuate shock, heel shock forces. And then in many cases, there is a twist component to plantar fasciitis where they go through some kind of toe pronation, forefoot pronation, or you'll see their foot whip when they're walking, and it creates a twist component on the plantar fascia. And I use the dandelion analogy. You're in the backyard trying to pull that thing out straight and won't come out. You give it a good twist, comes right out. Well, a plantar fascia will tear off the medial tuberosity much more readily if it's not just being pulled in 2 axes, but being twisted like a DNA coil in 3 axes. It'll pull right off the bone much more readily. So we look for forefoot varus and valgus in conjunction with plantar fasciitis and also the rigid cavus foot. There's also one more type. If someone really everts with the calcaneus, they're everting the medial tuberosity of the calcaneus right into the supporting surface, and that can drive plantar fasciitis.
And then on your sheet, for the people who are wanting to use you for orthotic fabrication, what are some of the modifications that you can mark in that?
So you want to order sweet spots for the heels,
Yeah.
which introduces an 1/8" poron component. Poron's an awesome shock attenuator, and it puts an interface between the shell and the foot so that they don't end up subsiding through the top cover and standing on the more rigid EVA shell. And then a lot of times the plantar fascia groove is required because they've got that significant bowstrung plantar fascia, and it's got to sit somewhere, and they don't like pressure on it from the orthotic. Mm-hmm. But if you just detune the arch, you're taking away the correction you're looking for, so you build them a little channel for that to sit in. And then you look for things like Morton's toe, you look for things like Morton's neuroma, you look for things like forefoot varus and valgus, and you post appropriately with that as well.
Tarsal tunnel.
So tarsal tunnel, in my mind, is in the same category as neuromas and metatarsalgia. It's kind of a pressure on the met heads, and you want to unload that pressure through a combination of recognizing whether the pressure is due to a Morton's toe or due to, in essence, for some reason, they're bearing way too much pressure under 2 through 4, and you want to employ a met pad, possibly poron caps to give them even more cush up front with the orthotic, and then occasionally, depending on the presentation of the met heads associated to those tarsals, wells if they have a prominent plantar flex met head.
And in a chronic ankle, inversion ankle sprainer, would you ever just take that piece of information and consider a rear foot valgus post
So I understand what you're saying, and I have to peel back and look at the fixed position of the foot in standing walking, right? And if it coincides with excessive calcaneal inversion, then we want to use a rear foot valgus post. But if you can see that they stand straight on that calcaneus, then what we do is we buttress the heel. So it's like the flared shoes we talked about earlier. It's widened out at the base of the orthotic so that as soon as they heel strike, it forces them medially. Now, if that's insufficient, then the next attack is a lateral rear foot post, valgus post.
And Shawn, those are the main ones that we wanted to talk about. But let's say there's no treatment going on. Let's just say that we're on a deserted island. There's no one to treat. All we have is your orthotics, basically. Someone's got an acute case of plantar fasciitis or Achilles tendon problem, whatever it might be. If the orthotics are perfect, what's a reasonable time frame for us to tell our patients it should be calmed down by when? And I know...
Are we using plantar fasciitis?
Let's use plantar fasciitis, yes.
Okay, so most folks don't stop walking when they have plantar fasciitis unless it's severe, right? Mm-hmm. And severe plantar fasciitis feels like you stood on some shards of crystal when you first get out of bed. So basically, the orthotic has to be in play for anywhere from 4 to 6 weeks in that case. And it also has a lot to do with the soft tissue intervention and what other practitioners with other skill sets than mine are doing to relieve tension in the lower quarter. Because a lot of times the fascial plane is basically recruited from further away than just that one location. And I try to remind folks, that the plantar fascia aponeurosis is just a big wad of fascia. And if it's been in compensation for a long time, it may have lost range of motion to adhesion. You can see plantar fibromatoses, and you can run a blade through their arches a lot of time, and you get Rice Krispies, all along it. So you want to do all those things and support that arch.
Like in a really difficult flared-up Achilles tendon case, what do you have for orthotic therapy for that classification of patients?
Typically, the real bad Achilles tendinopathy case can be traced to some form of misposition of the heel somewhere through stance phase. And believe it or not, the number one driver for Achilles issues is the foot is either overpronated through forefoot at toe off or underpronated, i.e. supinated. So they're not getting the heel to rise up over the forefoot in its neutral, and the Achilles bands are being strained in inversion or eversion, so they're not equally loading and grabbing the heel. Some of them are slack and some of them are totally overloaded.
And our patients get hung up on what they find on their x-rays or what their podiatrists are telling them. For example, heel spurs, okay? So we educate them on that is most likely not their pain generator. But the question I have for you, Shawn, is it ever their pain generator?
So heel spurs are, the periosteum around a bone is really what that medial plantar fascia band's attaching to, right? Mm-hmm. And as it tears minutely away, it pulls the periosteum away from the medial tuberosity, and the body's natural reaction is to fill that. It's like picking up a nose tissue off of a countertop. There's going to be a void up in the middle of it as you grab it from the center. The body fills that with the spur, and most cases the spur grows anteriorly and superiorly. So you are not walking on that spur, but all of the inflammation as that plantar fascia threatens to tear away from the calcaneus is right there, and that additional surface area formed by the spur is the body's attempt to create a greater surface area attachment site for that medial tuberosity band in an attempt to prevent it from fully ripping off.
Wolf's Law. Ever heard of it?
Yeah. Isn't the body so smart? I mean, it's just insane.
So in essence, you're really not standing on those spurs, but they're a part of the problem because the inflammation is centrally located in that spur.
So the answer is no, basically.
Yeah, in most cases.
So why don't we switch gears? Because this is a question that chiros and the PTs always ask. Footwear. So obviously, if we do decide to do orthotic therapy, we want a neutral shoe. Let's start there. So what are some neutral shoes that you recommend for people after we've, fit them for an orthotic? We're going to perhaps have them go purchase a new pair of shoes. What are the neutral running shoes you like, dress shoes, men and women, that will work with your orthotics?
So in the running shoe environment, I have been putting people in the Topo Ultra Venture because it has a 5mm drop, but it has the ultra forefoot toe box that many of our patients love because it's nice and square and provides a bunch of toe room. I'm not a huge fan of ultras because a good percentage of patients don't do well with the zero drop shoe. New Balance has a fresh foam line that works pretty well. Saucony's got a couple models like the Echelon and their trail model, the Peregrine, and the Asics does pretty well with the Cumulus and the Nimbus for a light cushion bottom shoe. You need more control, you could use the Asics Gel Cayano. If you need basically a more straight-lasted shoe, because a lot of the shoes I just mentioned have a semi-curved last, which means that they're not fully straight. They kind of curve medially as you move forward in the sole of the shoe. Then we go with New Balance. But around here, we don't have as much. We have a lot of up and down and some pitched surfaces. So I recommend Solomon's. They've got a bunch of speed cross and trail type shoes like that. And then we'll bump up into low top hikers. We recommend the Merrill Moab Ventilator. We recommend the Keen Targi, which comes in a low, mid, and high. We also recommend the Loa Renegade. And then as we move up into boots and more control, we recommend the Loa Renegade in a mid or a low. We recommend Echo's Trax. And we recommend Mindel, which has several really high-end offerings when you're looking for full control.
And then dress shoes, because this question.
So dress shoes, I send back towards Echo if I can help it. Yeah. Clark's has a few offerings
for the females.
Yeah. Clark's actually has a couple men's shoes. Rockport has a decent dress shoe, although if you don't like their hybridized, I'm going to walk all over this European town shoe, then you don't like
Rockport. Social suicide, put on a pair of Rockports.
Right, right, yeah.
Your life's over.
Yeah, so I don't want to name brand, but I throw people into the Nordstrom situation, because Nordstrom's kind of decided they weren't going to sell garbage and they sell the highest line shoes. And number one is most dress shoes don't come with a factory removable insert, giving us fits when it comes to fitting a sport athletic orthotic into that shoe. And we have to back engineer into a Met length dress orthotic, which gives us more or less opportunity for postings and control.
It was interesting. Tom was talking to us, and we were talking about zero drop. We asked him, because everybody was talking about it. And he said, what's interesting, he said, the recreational runner loves them. He goes, and he's like, I'm working with, all the top Kenyans and everything. He's like, they all love a little bit of heel support. He's like, the best, marathon runners in the world, they literally hate zero drop for some reason. It's kind of this weird irony, because you think they'd be the ones who love it.
Right.
But then like these recreational runners, they love the zero drop for some reason, but the really great runners actually, for whatever the reason is, they like a little bit of heel rise.
Yeah, and how much of that comes along with giving them a little more like landing pad, right?
Right.
We don't know without looking at like a really complicated system how much that's packing out at heel strike, and the forces at heel strike, say in the Boston Marathon, are just incredible,
right?
Like pounding, right? So they might be just feeling like they need more cush, but there is something to be said in any case where you've got restricted range of dorsiflexion in, say, the first ray or in the ankle, and then you place them in a zero drop shoe, you're demanding a greater ankle and first toe dorsiflexion range of motion. So considering a lot of what we see, which is ankle restriction and first ray hallux limitus and rigidus, is when you put them on a bit of a positive heel, you're shortening the demanded range of dorsiflexion, is particularly out of the ankle. So rigid cavus foot is not a candidate for a zero drop shoe.
Right. So we did a kind of a diagnosis specific little section. Now, if we had like a 30,000 square foot view of, foot function, and you have a foot that is unable to be the adaptive terrain
mobile adapter
after heel strike, what does orthotic therapy have to offer that rigid foot that isn't able to adapt to the terrain the way that we would like it to?
Well, so we have to believe that if we watch that foot walk across a hard man-made surface, that we're not going to see ideal stance phase mechanics, right? So they're already tossed a little bit of instability. So if nothing else, the orthotic gives them a start from zero, so that the little bit of range of motion that they do possess isn't overemployed just getting their foot to a neutral position to a hypothetical transverse plane.
And then as we're going from mid-stance to terminal mid-stance, then we have this key transformation of the foot that has to occur. And I use the example of a pogo stick, which kids don't use pogo sticks anymore. But we always talk about, like, if you were coming down and the energy that you would be absorbing in a pogo stick that's essentially pronation.
Yeah.
And you're essentially using that elastic stored energy to then regird and create supination. So then if we go to that phase after the phase that we were just talking about, now at mid-stance, terminal mid-stance, when we're getting ready to prepare for toe-off, we need the foot now to turn itself into a rigid high gear push-off lever, rigid lever. What is orthotic therapy able to offer that foot that is doing too well in the adaptive phase? And now that foot needs to be better at being a rigid lever for toe-off.
So it brings their forefoot to its God-given neutral, which is not defined by the supporting surface, but defined by how it grew off the midfoot, basically, so to speak, right? So if there is any kind of malalignment between the forefoot plane and the supporting plane, then they're going to go through an adjustment. And we can do one of two things. We can allow them to get there if they have the range of motion. And most rigid feet still have more range of motion anterior of the mid-tarsal line than they do posterior of it, because we just naturally have more flexibility in our tarsals, right? So if they're going to get anything accomplished, it's going to be in the terminal stance phase. And the other component is where they don't bear any weight through the midfoot ever, because they don't accommodate, like we said, their foot doesn't lower, it never touches anything. We're distributing pressures off the heel and off the forefoot into the aponeurosis of the midfoot.
If you took average people walking around in Idaho Springs in your town here, in your opinion, how many percent of people just off the street do you think might require an orthotic?
So that's a good question, because, obviously we get this crazy cross-section in the lab where almost everybody can benefit from an orthotic because they've been kind of told you need to go there, or referred, or their neighbor told them. But airport here around town, it's in the 40 to 50% of people, like one of two people will give some type of evidence in their gait cycle that they're compensating for something.
May not be necessary, but could be beneficial.
Right, like something that you, with a trained gait analysis, may ferret out, an asymmetry in the way that they're moving through stance and swing phase on either side. But if we peeled it back and said, all right, well, I've only been in practice for, say, 3-4 years, and I'm only really adept at identifying gross deformity, then we're talking more like 15%.
Right.
Yeah.
So resources. So you and I have talked over the years. I mean, obviously we both think a lot of Tom Michaud.
Yeah.
But we also both like Val Massey's book. And what else am I missing? What other books do you like?
Well, there was a couple books early on, and I wish I could just spit off the names of them without looking at their titles. But one I think was by Rene Calais.
The medical doctor, the artist. Yeah.
And he did a lot of stuff on the foot.
That one's called Foot Pain, actually.
Yeah. And then, our latest Pedorthtic 101 book isn't so bad. It kind of goes through some basics on what the idea behind casting for and providing an orthotic is. Introduction to Pedorthics, it's called. And that can be found at the pedorthics.org website in their bookstore there, basically. There isn't enough for it. The answer to the question is there's not enough literature, right?
When's your book coming out?
I got to sit down and write it. I got to find somebody to make all these.
They don't write themselves.
No, they don't. But I'm definitely looking forward to that phase of life.
Yeah, definitely. Well, how do people work with you? What if you got some chiros here that are needing some help with orthotics?
So, in essence, contact the lab or reach out through the website to us. We pride ourselves in requesting more data than most labs, right? So, one of the things that I think is ludicrous is that if you've got a case that's just not meat and potatoes, and you're not sure what you're looking at or what the solve is, why wouldn't you at least have the capacity to send some still photos and some video of the patient's gait, kind of introducing that patient to your pedorthist at your lab so they can see the third dimension, because we're asking for prints and we're asking for a semi-detailed design form, but we don't want to make it complicated for you. What's really critically important is your cast, and we're happy to train you through that to make sure you're getting a good image of the foot, and then giving us enough data to identify what your patient's going to need if you can't identify it.
I love it. we have a case that Brett and Shawn are working on, and so we're still trying to figure out how to make that all work as far as a case presentation. But I think it's going to happen. So I think we'll have start to finish.
And we're sitting on one with Tom too.
That's right. Yeah. So I think we'll I'm going to make Brett, when we get back, cast a couple feet, and we'll show that process, and then now we have the back end with Shawn. So
cool.
Start to finish, we'll be able to show it. So I'm always blown away by how intricate these are, but they're not overbearing. That's what I love about your design too. Like it's very, you say it's not meat and potatoes, but it is meat and potatoes. It's the big findings in the case and the best things you can do for it. So.
Yeah, you unravel it from the big stuff first, right? Mm-hmm. And a lot of times you can't really tell exactly what's going on. I like to think that we get a highly compensated person in, their gait's compensated, their presentation's compensated, and it's complicated and it's hard to discern what's the driver. So a lot of times I say, take a leap of faith, get a set of orthotics in there, get them compensating even 20% less, and a lot of times that magically unclouds the image of what the real dysfunction is, because they can get themselves so worked around a problem that you can't even identify what the real problem is until you get them out of some of the compensation.
The other thing too, I think the quality of these, I mean, no one puts more time into the quality of orthotics than Shawn. The other thing is the price point is so awesome to me. Like, I think we charge $350 or something like that. I mean, like $350 for this.
5 years.
That's to the patient.
5 years worth of an orthotic. Yeah.
Yes. I mean, that's not what you're charging me. That's like to the patient, which I think is out of this world. Because if they, pay cash at the podiatrist, I mean, this is somewhere between $500 and $800.
For plastic junk.
For junk. And I mean, this is what I found is patients actually, they expect that amount of money. That is not out of line for them. So
not at all.
And two, I mean, I send my orthotic castings to Brett just because he's better at doing it. Yeah. He's done it long enough, and I just had one that I sent to you, Jeff, and he was blown away by like how intricate, how much time Brett took to do it, explain the process, and then when he got it back, like how it was actually like what they talked about, like the rubber met the road, and so that's just awesome.
Yeah, it's a dying art in this sense that there aren't a lot of people left that want to work that hard to make them correctly. And it's been a struggle through the 18 years the lab's been in existence to find the right individuals who share a passion for it, who may have seen so much other garbage out there that they want to do things in a certain way. And we're kind of running short on Pedorthists in this country. Like, there's not enough of us.
Well, we're trying to convince him to move to Troy, right?
Yeah.
I mean, that's going to happen. And then once that happens, then we'll have the full Gestalt education Pedorthist track and the whole 9 yards, and we'll get some more people doing it. So anyway, Shawn, thanks for showing us.
Thanks a lot, Taylor.
Thank you for.
Thanks a lot, Brett.
Thanks always.
You're a true.
Really appreciate you guys coming over.
Man, you're a true artist, and man, there's so much good stuff in that podcast. That turned out awesome. So go back and listen to it again, guys. And what's the website?
ExtremeFootworks.com.
Beautiful. I'll link it in there. So I forgot to shout out our last coffee shop, but Westbound and Down, awesome coffee, Bloom Coffee, and our Sweet Bloom. Our boy Nick Hedges suggested it, so it was awesome.
Yeah, good food in town here for the few offerings that we have.
I love it. It's an awesome town. So make your way up here to Idaho Springs on your way to Breck. All right, guys, have a great day. We'll talk soon. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.